happened? There we go. We are recording.
Okay, it still says we're in a practice session, so that's
Yes.
okay. So that I was thinking that we might not have as many people because the HCBS listening session is happening right now.
Yeah, I was listening.
Yeah, I
Is
was
there
in
a way
it
I can
for,
stop recording while we're talking? Right here's recording. Hello, everyone. It is 3 o'clock. We will give people just a few more minutes to get logged in. However, just a reminder to everyone that your cameras are turned off and your microphones are muted. Please use the Q&A function if you'd like to ask questions. And we will be sending out um, the link to the recording and as well as the handouts from today's webinar. And I think that's all we have, but let's just wait a second. I see the numbers still going up that people are logging in. So maybe let's just give people a few extra minutes to get logged in. All right, so just a reminder again that the chat is turned off, but you may use the Q&A function to ask questions, and you will receive a follow-up email with a link to the recording and also a PDF of the slides from today. So today we have Marie Eagle with us from the ARC of Michigan, and we're going to be talking about supports coordination.
all right, ready to go? Okay, thank you, Heather. I'm gonna apologize in advance for my voice. I am fighting off a little bit of a sickness, so my apologies. Let me share my screen. Uh, can you see that, Heather? Is it sharing yet?
It's coming. Yep, there we go. Perfect.
Oh, okay. Um, oh, no, are we sharing still?
I'm not seeing your screen. Can you try to reshare? Yes. Now I see your
Um,
screen.
okay. Okay. So today, we are going to continue our little mini series on behavioral health services. Uh, excuse me. And today we're going to focus mainly on targeted case management. Uh, so these first few slides I just kept from our first two previous webinars about the overview of all of the behavioral health services. So the first slide that I just skipped over talks about the different Medicaid state plans and then the specialty behavioral health services waivers. So we have the habilitative support waiver, the children's waiver program, the SED waiver, and then your state plan, your ESPSDT, and your iSpot. Laura talked in detail about what each of those waivers cover, what population. So if you want some more specifics on that, you can go back and look at those other presentations. But these are included at the top of each, excuse me, um, slide to talk about which waiver is covered for each service. So education assistance and service array, this talks about the HCBS final rule that talks about how services must ensure that the individual receives services in the community to the same degree of access as individuals not receiving Medicaid home and community-based services. And so I kept this in here specifically because, our targeted case management, our case management slash support coordination service is the one who is primarily responsible for ensuring that services are planned for in a manner that is HCBS compliant. And so considerations for service options, obviously we must be doing an assessment of need. Um, and that is a entirety of need for the person. We're not talking specifically about services. We're talking about needs of that person as a whole. And service recommendations may be part of that, in addition to supports, in addition to natural supports and community supports. And again, this is another critical part. We look at this when we look at the site review, and this is just a critical piece of planning when it comes to behavioral health services. And this is that all important golden thread, this mythical golden thread of services that starts from eligibility and assessment, where we are determining need for what the individual, again, needs. Um, oh, I'm gonna just click through all these. I don't know how this slide works like this, but so we're doing evaluations, whether that's from somebody in the community, a medical professional, maybe of a need, somebody within the community mental health system. That's where we're making our evaluations and our recommendations for what the needs are, and then that ties into the person-centered planning process. So once again, we're using that pre-plan, gathering the information, people necessary to make a determination for what we're going to be discussing during the planning meeting. Person-centered planning, which is based on the person-centered planning process. It is not a service just for the sake of a service. This is, again, a very quick overview of this golden thread, but this is what we look for. This is what we use to measure that person-centered planning is occurring. And then service amount, scope, and duration, it must be sufficient to reasonably achieve the purpose in the plan. So this is where the services that are authorized and are implemented are sufficient in amount of service to ensure that the goals can be met, and delivery of service to ensure that service delivery is appropriate and meeting the goals in the plan. And we're going to keep these slides at the beginning of each of these webinars just to do a quick overview to remind everybody of the core principles of what we're looking for and what we're looking at when it comes to services within the behavioral health system. And then last and certainly not least is the whole person-centered planning. And so the idea behind person-centered planning, we all know, but it must consider social services and community supports that are crucial for full participation in community life. We must apply person-centered planning for individuals with behavioral health needs and consider environmental factors and other available resources. So again, we're talking about planning for someone's supports and needs as a whole. We're not simply looking at what that person needs within the behavioral health system as like a black and white service. Um, and I forgot, Heather has been our most recent in the field case manager. So I want to invite her to jump in at any point with it's been a hot minute for me, recent thoughts and experiences that you want to add to anything that I say today. And so, of course, the person-centered planning process is for the person to identify their life goals and decide what medically necessary services and supports need to be in place for them to have work toward and achieve whatever those life goals are. Um, so, oh, sorry, excuse me. Again, this is not an all-inclusive list of all of the services, but just some of them. And I would invite you in the chat if you would like to put any specific services that you want to see. We're not going to be able, obviously, to get to every single service, but if there are services that you want us to go into a deeper dive in one of these webinars, that please throw it into the chat, the Q&A, wherever you can put your feedback in, and we'll take that into consideration for our future webinars. And so again, I wanted to start with case management because it is like the core service that is guiding and planning, and that's your main connection for beneficiaries who are receiving services within the system. So I think that it was a great place to start when we're talking about service delivery um, and services available. I also wanted to focus on case management, support coordination, whatever you're going to call it at this point, because we do see as part of the ongoing site review and the interviews that we complete with people receiving services, we see um, consistent inconsistency in satisfaction with delivery of the case management function across Michigan. And so, we often will hear things like, well, it depends on who you get, from X agency. And in no way is this any sort of criticism of the behavioral health system as a whole. We really just want to share what people's experiences are and currently are with the system in the hope that we can help, guide people to continue working to improve people's experience and access to services. And so because there is consistent inconsistency with satisfaction, I really thought it was important to talk about the role of the case manager. And so we have a couple of different terms. So targeted case management is I pulled this from our original overview. It's a person who helps write the IPOS, the individual plan of service, and make sure that the services are delivered. Their role is to listen to the individual's goals, help find services and providers inside and outside the CMHSP that will help achieve those goals. And they may also connect an individual to resources in the community for things like employment, community living, education, public benefits, and recreational activities. And I'm going to touch on this a little bit more as we go on, but I think that's really important because we seem to have, migrated a bit away from a true like case management coordinator who is helping people access and find resources in the community and not just those mental health services. Um, and so we're going to get into like some of the core competencies, the Medicaid language that talks about what the core competency requirements are for a case manager or support coordinator throughout the presentation. And historically, let me back to the next slide. um, we kind of had a split and it was called a targeted case manager, TCM. If you worked with, like maybe the SMI, the MI, the children's population, and then it was called a support coordinator if you worked with the IDD population. Um, that has changed in recent, and it was labeled that way within the Medicaid manual. Um, and within different chapters with different language. And so now there is one chapter only that is called Targeted Case Management and slash Support and Service Coordination within the Medicaid manual. It is part of the state plan or ESPDT. Um, so it's not attached to any of those single waivers with that specific language anymore. So you do not need to be on one of those habilitative children's or SCD waivers. Um, again, state plan or the SDT for children. So there are three main roles, though, within the Medicaid manual for this role. You have your targeted case manager, your support coordinator, or your support coordinator assistant. And I pulled this language, and we're going to talk a little bit about it more as we go on. The beneficiary would have only one of these three possible options. So you would have one of these three roles assigned primary to your case. When a support coordinator assistant is used, a qualified support coordinator or targeted case manager must supervise the assistant. And we're going to talk about qualifications later, but I think that's important to point out because there has been some confusion out in the field about when you can use a support coordinator assistant, what you can use them for, and how you can, if you can only have one of them, then they have to be supervised by by one of those other two roles. And so I think that it's just, again, like, nuanced language, but, your support coordinator assistant in that case is your primary case holder, and then their supervisor would be a qualified support coordinator or targeted case manager. So we'll go into that more, but just to clarify that. So targeted case management, this is language from the current Medicaid manual chapter. is a covered service that assists beneficiaries to design and implement strategies for obtaining services and supports that are goal-oriented and individualized. And the services include assessment, planning, linkage, advocacy, coordination, monitoring, et cetera, et cetera. You can, read on the screen. And so, historically, targeted case management was just what it said. It was targeted, it was focused, it was a very specific amount. You were going to receive this specific amount of case management for these specific purposes, and that was it. Primarily, we see this with the children's waiver and the SMI population. Whereas support coordination was more of like you're going to receive this, but you're also going to receive this, and it's going to be more of a PRN, right? So you're going to as needed as well. And so the Medicaid manual language, even within the new chapter, is very extensive when it comes to the support coordination. Excuse me. And so I want to go through these, excuse me, and talk about all of the functions that we do expect to be done by a support coordinator. And so this also gets into support brokers, which we'll talk about a little bit more, and how you distinguish between the roles of support coordinator, assistant, and support services and support brokers, which we get a lot of questions about. So again, functions performed or otherwise designated representative that includes assessing the need for support and services and assurance of all of the following. So again, we are assuring that planning and or facilitating planning using person-centered principles is occurring. And that we are developing the individual plan of service using that person-centered planning process. We're linking, coordinating with, following up, advocacy with, and or monitoring with specialty services and supports and other community services and supports. And so the part that I want to focus on is that other community services and supports, right? So one thing that we hear frequently is, people will have a need identified in the plan, identified through the person-centered process, and they're more and more frequently told by the case management entity, person, provider, if you can find that, great, like let me know. Or, something similar to that. Or, maybe like, well, we have a list. Here's this list. Um, make some phone calls, let me know if you have any luck kind of thing. That's not what we're talking about when we're talking about linking to, coordinating with, following up, and advocacy monitoring with other community organizations. Um, and so I just like to point that out because again, this is Medicaid manual language that we expect to be providing from support coordinators, support coordination role. That is maybe where we've moved a little bit away from that. Um, and so I, I just want to point that out. Heather, do you have any like thoughts from your time as a case manager when it comes to that kind of role?
Um, Part of it is just knowing your community, working in the community, and making connections with, with other families, with other people who are going through similar situations,
Thank
and
you.
being able to share that information.
Yeah. And so again, brokering of providers of services and supports and assistance with access to entitlements and or legal representation. So again, we get a lot of questions about things like Social Security benefits, dealing with DHS and how do I apply for X or, I want to explore Z. Um, and families especially are feeling kind of like they're out in the wind to try to navigate these things. And we just want to remind folks that that is the role of a support coordinator to ensure that they are assisting with accessing all of those types of services, helping people understand, whether that's filling out an application or, helping them make the phone call, whatever that looks like. Um, and again, coordination with Medicaid health plans, Medicaid fee for service, and other healthcare providers. So, a lot of time that's, we have that coordination of care requirement, a form that we want to see that you're coordinating with doctors' offices. Um, And this also includes things like coordinating with, schools, like IEP attendance, assistance with advocacy for IEPs if needed, things like that. Um, is there anything you want to add to that, Heather?
Um, no, I think you covered it.
Okay, excuse me. So again, sports coordination, support strategies will incorporate the principles of empowerment, community inclusion, health and safety assurances, and the use of natural supports. So you'll work closely with beneficiary to assure ongoing satisfaction with the process and outcomes of support services and available resources. So I just think that this is really important language that we remind folks we're looking at all available resources. We're looking at community supports. We're looking at natural supports. We're not just looking at the list of Medicaid services. We're not just checking off CLS and respite and saying, okay, we got your needs covered. If it does cover needs, great. But we want to make sure that we're having like that full conversation when we're helping people plan for their lives. Um, okay, now the role of a support coordinator or assistant. So the role of support coordinator assistant is to perform the same functions that I just listed. So 2 slides ago, as they are needed in lieu of a support coordinator or a case manager. When a support coordinator is assistant is used, a qualified support coordinator or targeted case manager must supervise the assistant. And so when we get to the qualification slides, a support coordinator assistant is not degreed. Does not have to be degreed. Can be, obviously, but does not have to be. And there's a specific modifier that you use for that when you're coding it out in your billing. And so because of that, they do have to have a qualified. So that's, and we'll get to what qualified means, like a QIDP, QMHP, must be overseeing that person. So that typically what that means in a practical sense is they're reviewing case notes, they're discussing, the cases with the support coordinator or assistant, they're providing that kind of clinical oversight, signing off on the IPOS, things like that. And there is not a specific, like, you cannot perform X, Y, and Z duty. Like, that was the Medicaid manual language that I just provided for what a support coordinator assistant can do. And as it said, the functions of the support coordinator in lieu of a support coordinator. And so I know that there are some areas that say, oh, well, we can't, they can only work with this population or they can't work with this, like that language, that's not language that is written in the Medicaid manual. Um, excuse me. Um, The services and supports broker, more commonly referred to as a supports broker, but this is the Medicaid manual language, so I used that. So again, a services and supports broker is used to explore availability of community services and supports, housing, and employment, and then make the necessary arrangements to link the beneficiary with those supports. Now, we have seen the use of support broker increase slightly over recent years, specific to self-directed arrangements, which is great. That is not necessary, however, right? A support broker can be in excuse me, included in any person's case who may want or need one. Um, so the role of the support coordinator or support coordinator assistant when a broker is used is to perform the remainder of those functions that we listed out on what now 3 slides ago, as they are needed and to assure that the brokering of those providers of services is performed. So there is still, so when a support coordinator, a support broker is involved, the support coordinator and support coordinator assistant is not involved, right? There is still a role. We just have to clearly define, and we'll get to that in a little bit, the roles for each of those providers. So whenever the broker provides any of the support coordination functions, it's expected that the beneficiary will also have a support coordination coordinator, case manager, or their assistant employed by the PIHP or its provider network who assures that the other functions are in place. So again, all kind of helping to line up. If you have a support broker, their role is to explore community resources and connect that person with those resources. Your support coordinator or assistant is there to ensure that that broker is performing those roles, and then their role is to still perform all of the other functions that that broker is not performing. And again, this is a very basic explanation of it, and then if they have both a support coordinator slash assistant and a broker, that plan of service must clearly identify the staff who is responsible for each function. So if we go back a few slides, we talk about all those functions of a support coordinator. And the broker is going to, maybe connect you to X, Y, and Z in the community, and that's their only role. That plan would identify exactly those tasks, and then that the support coordinator or assistant will be doing all of the other tasks as required within the role of a support coordinator. So this is also from the Medicaid manual chapter on case management, and it talks about caseload sizes. And choice of provider. And this is also something that we know in practice is very difficult in practice for many, many reasons to accomplish. But this is the language in the manual, and so I wanted to point it out that caseload size and composition must be realistic for case manager to complete the core requirements, which we have about 3 slides of those, as identified in the individual plan of service developed through the person-centered planning process. So whatever we're putting in our plan is what our support coordinator will be linking, monitoring, and coordinating, overseeing if it's a broker, things like that. Their caseload size has to allow them to competently and realistically complete those requirements, their job essentially, right? So if we, a lot of the people that we interview through the site review will say, well, they're doing the best that they can, but they've got so many people, right? And so and as people who have worked in the system for many, many years, we know that this is a big burden of the system, but this is what the language requires. Um, and then beneficiaries must be provided a choice of available qualified staff upon initial assignment and on an ongoing basis. And so again, this is something that we look at and we talk to folks about during the site review as were you provided a choice of case manager, and I would say, I think the data shows that, over 90% of the time it's no. We get who we're given, and unfortunately, more often than not, it's, if things go sideways, then, we may be able to get somebody new, but even in those instances, it's often still not providing a choice. And so again, this is language that I just want to make sure that everybody is aware is in the Medicaid manual. Heather, do you have any thoughts on this?
And if you choose a supports coordinator and things aren't working out, you do have the right to request a different supports coordinator.
Yeah. And not just once, right?
Yes.
I mean, not that we want like a revolving door of like, I don't like you, 2 weeks later, I don't like you, right?
And
But
I always try to remind people too that just because you're asking for a new supports coordinator or a new direct care worker or a new therapist, it doesn't, sometimes it's not a good fit. It's not any one person's fault. It's not your fault as the individual. It's not your fault as the provider. Sometimes it's just not a good fit.
so the next few slides we talk about, so these are those core requirements that we reference as the core requirements of support coordination. So these are the requirements that caseload sizes have to be realistic enough to allow all of these to be completed. So again, assuring that that person-centered planning process takes place and that results in an individual plan of service. That independent facilitation of the person-centered plan is made available. And it goes on to say that individuals that receive behavioral health supports have the right to choose an IF to facilitate the person-centered planning process. I debated putting independent facilitation in this presentation as well, and I chose against it for a variety of reasons, but we do know that this is also one of probably our weakest areas across our indicators in the state when it comes to quality person-centered planning. Um, that knowledge of independent facilitation um, is pretty low consistently across regions in our state. And so this is certainly an area that we can work to improve to ensure that people do understand the option of independent facilitation and how it can be a benefit for folks. That we see it used most often in times of like, mediation, in times of conflict, and that's really obviously not the intent of an independent facilitator. I used to We bring in independent facilitators for folks who, I don't know, gosh, we've been working with for a really long time and I was just out of ideas. Or, we just wanted a fresh brain and, just some new eyes and new thoughts to come in. And, it really allows that case manager to just be part of the process and not in charge of facilitating the entire thing. So it's just another option that we really need to be improving on making sure that people are aware of and how to access it should they want to use it. Um, so again, we have to ensure that the plan of service identifies what services and supports will be provided, who will provide them, how the case manager will monitor that service. So what does that mean? Is that a face-to-face contact? Are they going to be reviewing notes? Like what is that monitoring to ensure that that service delivery is appropriate and meeting the plan goals? What does that look like? Um, for each service and support identified under each goal and objective. And so again, like this is where in these parts of the plan where we can identify the roles and responsibilities of if we're going to have like a SC, an SC assistant, a broker, like those kinds of things in place where we can specify who's going to be doing what for within that goal. Um, and then they are overseeing the implementation of the individual plan of service, including supporting the dreams, goals, and desires for optimizing independence, promoting recovery, and assisting in the development and maintenance of natural supports. Anything on that one that you want to add?
And when these conversations are happening about, who you're going to see and how often, it's important to make sure that the individual, the person served, is a part of that conversation, and they may have an opinion on how often. We hear it both ways. Some people are like, I wish I could see my case manager more, and some people are like, I have meetings all the time, and they would maybe like to reduce that. So everyone has an individual preference, and their needs and situations are different, and they definitely need to be a part of the conversation.
Thank you. Yes. Again, assuring the participation to Heather's point of the beneficiary on an ongoing basis in discussions related to their plan, goals, and status. And that we are identifying and addressing gaps in service provision and addressing all issues. And if not, there's that whole section of the plan where we say, if this is not addressed in this plan, why are we deferring it? What are we doing? So we're addressing all issues, for example, housing and employment. And if not, why not? What are we doing about it? Like, why isn't it being addressed within this plan?
Lori,
Um,
we do have a question in the Q&A
oh, great.
about independent facilitators.
Okay.
So, is it only the consumer or the guardian that can request the independent facilitator, or can a CMH request involvement?
I believe current language is that the individual and or guardian can request an independent facilitator. That's a great question, though. Let me take that back and we'll talk about that a little bit more. Um, that's a really interesting question. I like that one. Thank you for
Yeah.
that.
There was another question about what is a realistic caseload number?
Oh gosh, I really wish I had the answer to that. I don't have it. I mean, goodness, back when I first started, I remember, I mean, and I'm gonna age myself, but back in the late 90s, our caseloads were like, high 20s was considered high. Now you hear people who have caseloads in the 60s, 70s, 80s. Um, so I think that that's a really difficult question to ask. I think that caseload type has a lot to do with it. In my last CMH, we had case managers who had lower caseloads that had maybe what we would consider a higher difficulty of cases who needed, more contact each month. We're going to have a little bit, more involvement, consistent involvement. So I think that it's really individualized, but I mean, honestly, your case managers are going to tell you that, right? If they're like, I can't do this, I'm not meeting my people's needs, I can't get what, and I'm not, and when I say I can't get what we need done, like not like getting the paperwork done, because so many people say, and it just breaks my heart a little bit. They like, I feel like they're just checking off boxes and trying to get to the next person. And if your caseload sizes are allowing you to only check off boxes and get to the next person, I'm going to guess your caseload sizes are too high because you're not able to actually provide case management for folks. You're building that relationship. One of the things that we look for in the site review is, do you feel like your primary clinician is spending enough time with you to truly understand you or your loved one's needs, what's going on in your life, things like that. And that's an inconsistent answer that we receive. And I think that a lot of it ties back to that, like our caseloads are too high, and we don't have time. And so it leaves people to be feeling like they're just a number, another number in somebody's week and not like that they're actually receiving meaningful case management services. And so that's what we really want to avoid. So I don't have a great answer. I don't think we're gonna, I don't think the department's gonna come out with a, you have to cap your caseloads at 30. Um, so it's a great question. I don't have a great answer for it.
Marie, we are having a couple more questions in the Q&A. Do you want to go ahead and answer them now as they come?
Yeah, sure.
Okay. So a question about natural supports. Usually that means parents, correct? How is the development and maintenance of natural supports part of the supports coordinator's job?
So natural supports does not only mean parents. Natural supports, so when I say a natural or community support, so a community support, might be somebody, another community provider, but a natural support is what we would consider, anyone who's not a paid community mental health support service provider. And so it absolutely is the job of the support coordinator to help connect people with their community to help build on those natural supports. And that doesn't mean that, we're going out and, trying to meet everybody on, at Walmart or things like that. But we are certainly trying to explore who do you have a connection within the community? What are you interested in into within your community that, and maybe let's explore, like if you're interested in gardening, let's work on getting you involved in a local gardening group. Um, and if you need like a paid support to participate in that local gardening group, say, then we're going to put in some CLS to help you there. And then you're going to build that natural support because you're going to meet people and you're going to make those connections. And so then you're going to have some more natural supports and you're building your natural community. It's kind of that idea of building that community around someone, and that's more what a natural support is. And so as you're building that, the more people that are involved in that person's life, the more support they're going to have in a more natural manner. Does that answer that question? I think, I hope.
Yeah, I think so. I think one that I see out in the field quite often is people develop natural supports through their religious organizations. So
Yep,
it might be somebody who's willing to give them a job or give them a ride or, make sure that they're attending whatever religious events are happening. So that's
yep,
what we
definitely.
definitely see a lot. The next question is about so at intake, individuals should be given a list of care managers and they choose who they want. Most of the time, individuals are assigned to who has availability.
That is correct. That is m almost always how it happens. A few times we had developed like support coordinator vignettes, which were next to impossible to keep up to date, with like, here's who I am as a case manager, here's kind of my areas of interest or my skill set, and then would be able to choose. But again, we know that based on, you know, lots of different factors, it's very difficult to maintain. But we do need to be providing choice. So whatever that looks like, at intake, definitely, I think that we should be providing some sort of list, some sort of system to develop a way to ensure that people are having the ability to make a choice for who is. I mean, this is like your main point, right, of contact within the CMH system, and so we want to make sure that that's a good fit. Especially based on, right, availability can always makes it difficult.
That's all the questions that we have for now.
Okay. All right, where was I? Okay, I will keep going and please keep asking questions. Um, so again, okay, coordinating the beneficiary services and supports with all providers, making any referrals and advocating for the beneficiary, That one's fairly self-explanatory, but again, like going back to that, like here's a list of providers, go make some phone calls. Like that is not providing quality support coordination. We are not just giving a, unless the person wants to do that, unless they're like, listen, I want to take control and I want to make these phone calls and I want to find a provider more, great. But most of the time, that's not the case. And so the support coordinator is there to assist through that process. Like, let's make some phone calls together, right? That will help with that relationship building.
Or
Or,
let's schedule some visits to go visit different,
exactly.
ABA centers or physical therapists, um, because that can make a difference.
Yes, exactly. And so again, that but I feel like it's self-explanatory, but maybe not. And then assisting the beneficiary to access programs that provide financial, medical, and other assistance, such as home help and transportation. This is another one that we get a lot of questions with. Like, we need help with, whatever it is, home help, transportation, all of those more like, I don't know, like ancillary, Medicaid, but not CMH Medicaid type services. It is the role of the support coordinator to help you access those services. Um, so whether that's, I'm going to help you with the application, we're going to submit it together, I'll be there when you do the home help home visit. Um, whatever that that looks like. Heather, do you have anything to add on that one?
Um, yeah, I think you about covered that. That's pretty good.
Okay, for me. Okay. And again, we touched on this one already. Ensuring coordination with the beneficiary's primary other healthcare provider to ensure that continuity of care. We have that requirement that has to be documented. Coordinating, assisting in crisis intervention and discharge planning, including community supports after hospitalization. Now, I know that this has been different in recent years, more so in the past, especially when it comes to the hospitalization piece, because a lot of hospitals have their hospital liaisons and they don't really want the CMHs involved anymore. Um, I also hear a lot of CMHs say, well, they're in the hospital, we can't bill for that. So, we're not gonna be doing that coordination, or we're not gonna, like that doesn't mean that we're not involved in the transition out of hospitalization, right? There's ways to do that, so that we are making sure that we are involved even when there is a hospitalization happening.
And
And again,
we do have a question that was back from the previous slide, but I think
oh,
this slide may also help to answer it.
okay,
I thought that we were supposed to help foster independence. So when we're talking
definitely.
about, helping someone go to Social Security to submit their application, things like that. I think you can still do that in a way that fosters independence.
Oh, definitely. Like way back in the day, I swear we kind of just like did everything for instead of fostering independence and encouraging independence. And so I certainly don't mean that in a like you have to help every single person submit their Social Security application. And yes, we want to be fostering as much independence as we possibly can. And so that's going to be, as with everything, individualized, person-centered for every single person. Some person might need a little bit more support than others. Others might need not any support in whatever that process is. So what that means for each person is that you're going to identify what their need is of support in whatever that area is, and then we're going to provide that support.
The
So
level of support that they need, whether that
yes.
is just a reminder about like, hey, I know your Social Security, something is due, have you turned that in? Versus like, okay, let me, you know, do you need help to fill that out? Those are two very different scenarios.
Yeah, exactly.
And
Um,
giving them the level of assistance that they need is how we foster that independence. Because
yes.
you
And
don't want to
so,
give someone a task that they can't do, but
right.
you don't want to do the task for someone where they can. Sometimes that's referred to as like scaffolding. We're supporting people where they are so that they can then, reach to that next level.
Yeah, exactly. And what we don't want to see is that, what we don't want to hear is, I need support and I don't know who to go to. I don't know who to get it from. and they have a case manager, right? So even like that's where I think it's so important that relationship building, that like ensuring that your caseloads are a reasonable size so that you can build that relationship with folks so that you know what kind of support they need and want, and that you're able to provide that while encouraging them to become more independent as you work with them. Um,
We
uh,
do have another comment in Q&A. It's a little long, but let me go through that. It seems that the supports coordinator role is county dependent. I know that one CLS staff also works in another county, and she said that the other county's supports coordinator has a lot of contact with her as a staff, whereas mine meets with us for 15 minutes a month if we're lucky and just goes over some questions and writes all the things we're doing. Um, that quite honestly sounds like the supports coordinator should be doing. Frustrating.
mm. Yeah, that is more common feedback than we would prefer. And so I guess my response to that would be that, it is up to you through the planning process to request the amount of support coordination, case management, and the tasks that you want assistance with that you feel like you need. And so if the things that we're talking about you feel like you need assistance with and you're not receiving, and you feel like those 15 minutes aren't adequate to meet your family's needs, I would request a plan amendment to more adequately reflect what you actually need and want to be receiving from that service. And I agree that it does, I mean, it's county specific, but it can also, just be provider specific within a county. It's based on so many different factors. And so we really just like our hope is to just keep improving the quality of the support coordination that people are receiving across the state. And in no way, saying that it's that people aren't trying right to provide good quality case management to folks, but just trying to remind folks of what the role is, what all of the core competencies are as expected within the Medicaid manual. Just to kind of put a refresher out there of this is what the service is. This is, as we said, our main point of contact for families. This is the person that you talk to. And so it's just imperative that this service is being provided in a really quality manner to folks. So again, facilitating transition, i.e. from inpatient to community service, school to work, dependent to independent, including arrangements for follow-up services. So we get a lot of questions about like transition age, right? So I'm aging out of school, like it says here, I'm aging out of school, I'm aging from, or maybe I want to transition from a more restrictive setting to a less restrictive, like I'm going to move from an AFC, I'm going to move into my own apartment, whatever that looks like. And then all the way up to like transition planning, a lot of the folks that we support now have aging caregivers, helping plan for what that transition is going to look like for that person when those aging caregivers are no longer able to provide that type of care, even if it's just decision making. So helping the team, helping the person that we're supporting plan for all of those life transitions. Um, that also includes assisting beneficiaries with crisis planning if they want it. Um, and then identifying process for after hours contact and assisting in developing social networks. That again goes back to the piece that we talked about in developing social networks, natural supports based around their interests, community involvement, things like that. So those are all of the core competencies. So that was the full list of core competencies in the Medicaid manual for a support coordinator slash support coordinator assistant. And now this is the staff qualifications. So a primary case manager must be a qualified mental health or intellectual disability professional. So that's QMHP or QIDP for all of us acronym users, which is all of us in this system. Or if the case manager has only a bachelor's degree, but without specialized training or experience, they must be supervised by a QMHP or QIDP who does possess that training and experience. And then again, services to a child with severe emotional disturbance must be provided by a QMHP who is also a child mental health professional. So there's some additional requirements attached to that. And then children services to children with developmental disability must also be provided by a QIDP.
We do have another question
Okay.
in the Q&A. With an aging and or sick primary caregiver and likely transitioning into a group home of some sort, what is the role of a supports coordinator in finding a placement?
Hmm. I mean, it's the same as the role would be if there wasn't an aging, was it a caregiver or a parent?
Caregiver.
Um,
It just says a primary caregiver, so that could be a parent.
so I mean, the support coordinator role would not vary in that instance as that it would for anyone else. So if there is like a guardian, whatever, whoever else is on the team as a support that can help make those decisions. We obviously want to use that person-centered planning process to help ensure that that what that person wants and needs is at the primary of that planning when it comes to finding placement. Um, you know, I, the Marie in me is like, ugh, do we have to transition to a more restrictive setting? Like, what are the other options? So, the support coordinator's role would be to explore to ensure that there are no other options, I guess, first to, make sure that we are enabling that person to be as independent as possible. Regardless of the sick primary caregiver, we're exploring all other options for other placements, other caregivers, like whatever that looks like, um, up to, potential other placement in a more restrictive setting. Um, but it would be the same as their role for whatever a new placement need would be. So they would have that same responsibility to help, explore options locally, wherever in the community, do those visits, all the stuff. Do you have anything to add to that one?
No, I think you covered it. Yeah, making sure you just explore all the options and find the best option for that individual.
Excuse me. Okay. Um, so staff qualifications for a support coordinator. They have a minimum of a bachelor's degree in a human services field and 1 year of experience working with people with developmental disabilities. If we're supporting that population, same thing, and 1 year of experience for working with people with mental illness if you are supporting that population. So a support coordinator assistant and a service support broker is less. We have minimum of a high school diploma and equivalent experience to the support coordinator. So possess knowledge, skills, and abilities similar to support coordinator qualifications. So experience working with the population that we're going to be supporting. They function under the supervision of a qualified support coordinator. Independent services and supports brokers must meet these qualifications and function under the guidance and oversight of a qualified support coordinator or case manager. And then this is from the HCPC code, provider billing requirements, just for funsies. The code that all case management, targeted case management, support coordinator assistant, support broker are billed under is T1017. There are countless, not really, a lot of modifiers that are attached to this code. The reporting is coded and billed in 15-minute units. Um, and again, QIDP or QMHSP or QMHP, children services must be a CMHP, um, which is a children's mental health professional or supervised by a CMHP while working toward becoming one. To any child with SED, birth to 20 must be provided by a CMHP or QIDP trained in the state required tools per the contract. I did not put that language in there. If you want it, we can always get it for you. And a support coordinator, assistant, or a broker must use the HM modifier, which is less than a bachelor's level. And again, there's lots of other modifiers depending on certain things, but since this presentation focused on these services, I wanted to point out that specific modifier. Um, and I think that's it. We made it through. We have a few minutes left. Were there any other questions? Excuse me. So sorry. Thoughts?
Uh, I do not see any questions, but we'll give people a couple of minutes and I'll just give everyone a brief reminder that we will send out the link to the recording and the PDF of today's presentations, and as well as an updated schedule of our webinars that for the remainder of the year. Link to the video and the PDF. Yeah, so I think those are the things that we will get out to you guys probably this week. And we will also be updating the website um, with the video when it's available as well.
Sorry, I just saw Millie's comment. I know. Thank you. At the SD conference, I had three or four, and I didn't make it to the end of any of them, so I was very proud of myself for this one. Um, okay. So again, if you have any specific services that you really want to hear more about, please shoot us. You can put it in the Q&A
Or an email.
or shoot Heather an email.
Yep.
And
And
we'll
my
make
email
sure.
is the same as Marie's, just Heather instead of Marie.
Oh, shoot, I didn't put that in
Heather
the
at
chat.
arcmi.org.
Yep. And so next month we'll do another deep dive into services. Not 100% certain of which ones those are going to be yet. In June, we will be doing Angela Martin from Wayne State University's CDI will be doing a presentation on the Danny plan, which is a great new planning tool that's coming to Michigan. And then in August, we will have a team of case managers, support coordinators who will be giving a much more in-depth real-life presentation on providing case management like real life style these days. So thank you everybody for joining us.
Thank you all and have a great week.